Okay, guys, we will start. Hi, guys. Myself, Dr. BANDHALA RAJAN. I am your ADRPLEXUS Dermatology faculty. Today, we are going to see about the Dermatology Restart Test and Discussion session. First of all, let me introduce myself. I did my MBBS in Tanjore Medical College and I did my post-graduation in MD Dermatology and Venereology in AIIMS, Jodhpur. Then I cleared an MRCP SE exam. So I just want to start the session with my small story, like how the exam got evolved in past 7 years from what in my vision. Okay, when I did a PG in AIIMS Jodhpur, it was 2017. Okay, now the year is 2024. Na? If you see, when I gave the exam, the pattern was like this. The more questions were conceptual based questions, like recall based questions. Almost 75% of questions. Only 25 to 30% were applied. But now you see, almost more than 80% of questions are of applied aspect. That the recall based questions have been reduced less than 20%. Then if you see, when I did exam, there are more one-liners. Now you see, there are more of case-based scenarios and problem-solving skill assessing questions. The next part is very, very important. If you see, when we gave exam, if you get 120 to 135 out of 200 questions, you will get a very good clinical seat, something like a radio, even Derm. But if you see now, even in the last NEET exam, you can see like even the people who got more than 150 questions correct, they may struggle to get a good clinical seat. So why I want to stress upon is the trend is changing. So your preparation way and your goals, everything should change accordingly. Like you should more focus on the clinical based scenarios and abstract thinking and problem solving skill questions instead of mugging up or worrying more about the one liners. Even if you are not able to answer the one liners, it doesn't matter because the proportion will be very less. So that's what I want to tell. And you have to keep your target as high as possible. Initially, I used to tell my students like, if you are getting 140 to 150, you will get a very good seat. But the scenario has entirely changed now. You have to target at least 180 to 190 questions correct. Then only you will get at least 150 to 160 correct. Are you getting what I am telling? Okay. With this small discussion about the trends of exam, now we will discuss about the questions we had in dermatology test and discussion session, which was conducted on last Saturday. Can you tell how was the question paper? Whether it is easy, difficult, or tough? Anybody? Can you just put a message? Okay, most of you feel like it will be easier. Okay, moderate. Okay, fine, fine. Okay, it depends. Some people it may be easy, some people it may be moderate. It doesn't matter. Now we will discuss the questions and how to solve these questions. Because of this changing trend, I made as much as possible more of clinical oriented questions and image based and problem solving questions. Let us start. The first question was, a 30 years old female construction worker presented an itchy crusted lesion over the bilateral hands. Histopathology showed spongiosis as a predominant picture. Spongiosis involves which layer? You see, it's a very lengthy question, but the question lies only in the last line, right? Spongiosis occurs in the which layer of skin given in the image, right? In this, first I will tell you what can be the clinical scenario, then it will be easy for you. Like if a construction worker is having itchy crusted lesion over the hands, means the person may be having some dermatitis or eczema to some substance like cement. Okay. So crusted lesion means it is an eczema. Since she is a construction worker, mostly due to cement. So it can be a contact dermatitis or eczema, contact eczema to cement, right? So here they gave one point like spongiosis as a predominant picture. So you can easily remember eczema is characterized by spongiosis, especially acute eczemas are characterized by spongiosis. Why I am telling this? Instead of giving this image, sometimes they may ask a person presenting with contact dermatitis over the hands, what can be the predominant histopathological finding they can ask. That's why I am telling. Now we will see spongiosis involves which layer of skin. Here they didn't mention any layers, just they mentioned the A, B, C, D. So you have to identify the layers. The topmost layer we know it is anucleated, so it is stratum corneum. The second layer is spinosum. Sorry, the second layer is granulosum, because you will have that keratohyalin granules, the dark granules. This large layer is spinosum, because the layer is having that spine-like connections between the cells, right? In between. This lowermost layer is stratum basale. Below that, this light pink part is dermis. Mainly, it is a papillary dermis. Now, before going to the options, we will see what are the changes in each layer, so it will be easy for you to remember. For example, if it is a stratum corneum, it is containing keratin, okay, dead keratin. So, if it is thickened, it is known as hyperkeratosis. If there are presence of nucleated cells, it is known as parakeratosis. Okay. Stratum granulosum, if it is thickened, it is hypergranulosis. If it is thinned out, it is known as hypogranulosis. Okay. In stratum spinosum, it is having this spine-like connections between the cells. This spiny is known as acanth in Greek. So if this layer is thickened, it is known as acanthosis. If there is a loss of that intercellular connections, these spinous connections are lost. So it is known as acantholysis, because the spines are lost. So it is known as acantholysis. If there is an intercellular edema between the cells, if there is an water in between the cells, means what will happen? It will something like a sponge, it will enlarge. So if that intercellular edema is known as spongiosis. Okay. Intercellular edema is known as spongiosis because it is a sponge-like structure, you can remember. Because of water, it will become a spongy structure. Okay. Now can you tell me which layer involves A, B, C, D? There are marked A, B, C, D. Which layer is involved in spongiosis? Anybody? Yeah, correct. It is spongiosis involves stratum spinosum. So the answer is option B. Right? This is a very important table. They can give directly also, otherwise they can give case-based scenarios. The next question, a 30-year-old male patient presented with multiple plaques and nodules over the limbs. Histopathology showed microabscesses composed of lymphocytes in stratum spinosum. The diagnosis is, here if you see, the main clues here are patient is having plaques and nodules over the limbs, and there are lymphocytes in the stratum spinosum composed of microabscesses, right? Now, for this, you have to know what is microabscess, so you can easily make out. The clinical points are just to support the diagnosis. First, there are 5 types of microabscesses in dermatology. Monroe microabscess, Kogoge microabscess, papillary tip microabscess, eosinophilic microabscess, Potterius microabscess. For this, I will just give some easy remembering points. If you have neutrophils, it can be 3 abscesses, okay? If it is eosinophils, that is eosinophilic microabscess. Potterier microabscess is made up of lymphocytes. So the main clue here is, for composition, you remember only Potterier microabscess is composed of lymphocytes. Okay. Others are basically made up of neutrophils. Portrait microabscess is made up of lymphocytes. That is the only thing you need to remember. Others are made up of neutrophils. Eosinophilic microabscess, the name itself suggests it is in containing eosinophils. Right? The same way, location wise, if you want to remember, you remember only Monroe's microabscess, which is present in stratum corneum, which is the first layer, right? All other microabscesses are present in stratum spinosum. Here also one easy odd man out is papillary tip microabscess will be seen in dermal papilla, right? That is very easy to remember. Now, this Monroe and Kogoch microabscess are classically seen in psoriasis. It is a very important MCQ. If there are microabscess made up of neutrophils in the epidermis, it is psoriasis. If it is in the papillary tip, it is dermatitis herpetiformis. If you have eosinophilic microabscess, it is seen in pemphigus vegetans. If you see lymphocytes within the epidermis, that is known as portrait microabscess, it is seen in, since it is lymphocyte, it is seen in cutaneous T cell lymphoma. Lymphocytes means it is lymphoma. So otherwise known as mycosis fungoides. So the answer here is microabscess composed of lymphocyte is known as portrait microabscess. It is classically seen in mycosis fungoides. Mycosis fungoides is a cutaneous neoplasm which is characterized by multiple plaques and nodules over the limbs. So that is one of the clue. Okay. So this clue confirms our diagnosis. Next question. A 20-year-old male presented with following skin findings. All of the following are possible causes except. They have given an image in that there is a black structure, black finding is seen in the flexural area. Initially, they used to give the direct term and they will ask what is the causes. Now they are giving just image and they asked you to identify the image and the causes, right? Can you tell me what is this finding? This dark necrotic slough. Can anybody tell me what is this dark necrotic slough? If you see such image in dermatology, it is known as Eschar. Okay. So first you have to identify it is an Eschar. Eschar is basically a dark necrotic slough. It is due to vascular thrombosis in that area leading to necrosis of skin. Now there are 4 options given: scrub typhus, Lyme's disease, ecthyma gangrenosum, mucormycosis. We have to rule out the things and you have to identify which condition it doesn't see. For that, we will see what are the causes of Eschar. The causes of Eschar can be divided into 2. It can be infectious causes or non-infectious causes. In the infections, commonly it is seen in scrub typhus and rickettsial pox. In the bacteria, both are rickettsial infections. Apart from that, you will see in a condition known as cutaneous anthrax. You might have read in microbiology, na? Cutaneous anthrax. Apart from that, it is seen in pseudomonal infection. The infection name is ecthyma gangrenosum. Okay. Apart from these, it is seen in fungal infection known as mucormycosis because the mucor fungus will occlude the blood vessels and cause necrosis. So they will have an extensive Eschar over the nose, orbits and all. In the non-infectious causes, it is seen in Purpura fulminans. It is part of disseminated intravascular coagulation. Okay. Apart from this, it is seen in calciphylaxis. Calciphylaxis is basically calcium deposits in the blood vessels seen in renal failure, chronic kidney disease, in end-stage failure. Apart from these causes, it is also seen in recluse spider bite sites. With this, we can make out Eschar is seen in scrub typhus, so it is out. Ecthyma gangrenosum is a condition, so it is also out. Mucor is also out. So Lyme's disease is the answer. Can anybody tell me what can be the cutaneous manifestations of Lyme's disease? It is also very, very important. Lyme's disease is characterized by erythema migrans. What you will see a ring, erythematous rim, which gradually enlarge in size. So, okay, it will gradually enlarge in size, seen at the tick bite site. You won't have an Eschar there. Spreading erythema. Right? So, this is a very important thing. Next, you will go to this image. A 20-year-old patient presented with following skin lesions since birth. What is the pattern of lesions? The options given are dermatomal, linear, segmental, and blastoid. There are various lines in dermatology you need to know. There are three common lines you will tell. One is blastoid lines. Second is dermatomal or zoosteriform lines. Third is Langer lines. In this, these blastoid lines are basically seen like curvy lines. The scalp, if you see, it is old. In the trunk, it will be seen like a spray or fountain pattern. In the limbs, it will be like an S pattern. In the chest, it will be in a S-shaped pattern. Okay. In this way, it will be seen. Basically, they are lines of embryonic migration, embryonic cell migration. Those keratinocytes and melanocytes are developed from ectoderm. They will migrate in this path only. So these are embryonic migration lines. Zoosteriform means, zoster means single dermatome. Dermatome is an area of skin supplied by single nerve root. That is dermatome. The main point in difference is it will involve the only one dermatome and it doesn't cross midline. Langer lines are basically due to the arrangement of collagen in the papillary and reticular dermis. So they are parallel to the collagen arrangement. If you do an incision parallel to the Langer lines, the scar will be less. Less scarring. If you see the dermatomal lines, it is classically seen in herpes zoster, which is a viral infection. We all know. Now, here we will see the image. Here you will see bilateral things. So, this dermatomal is out. And if you can see these S-shaped lines, here also you can see these S-shaped lines. So, it is more towards blastoid pattern. Linear pattern means it will be seen only single area. Single area you will see a linear line. Segmental means it can involve multiple areas, but there won't be any specific arrangement. One area, but no specific arrangement. Okay. So the answer here is blastoid lines. Next, a 10-year-old boy with fever and rashes all over the body. A bedside test was performed in the patient. It showed the following findings. The likely diagnosis: measles, varicella, dengue, sarcoidosis. Anybody? Anybody want to try? First, they have given a fever with rash. So the patient is presenting with some infectious condition, right? So we identified it's an infection. Now they didn't glass light test. They just press the glass light. They are seeing whether the redness is blanching or not. You press a glass light. If it is blanches, it is erythema. Because of increased blood flow, it is there. If it is doesn't blanch, it means it is purpura. Because what happened here? Here there is a more flow in the erythema part. But in purpura part, what happens? Their RBCs are coming out of blood vessels and deposited in the skin. So it doesn't blanch on pressure. So they are given a fever with a rash was there, which is an infection ideally, a rash with purpura. Okay. So now you can easily identify if a person presenting with infection with purpuric rashes. What are the cause of purpura? Commonly thrombocytopenia is one of the cause, right? So out of the option, you can easily make out. The answer will be dengue. Dengue only, they will have a multiple purpuric spots. If you see measles, there will be more erythema. So it will blanch basically. In varicella, we know there will be more of blisters rather than erythema. Sarcoidosis, it doesn't have these kind of lesions. There will be plaques and nodules. Right? We are doing this pressing the glass eye and seeing what is happening. Now, this procedure is known as a diascopy. Okay, it is known as diascopy. There are various uses of diascopy in dermatology. The main thing is to differentiate erythema and purpura. That is the first use. Apart from this, if it is in lupus vulgaris, which is a type of cutaneous TB, we will see in another question, and sarcoidosis. If you press the lesions, you will see a brownish color. Brownish color. That is known as apple jelly nodules. That is a very important MCQ, apple jelly nodules. Right? We'll move further. A 30-year-old male patient presented with following lesions over the lower lip for past 3 days. The next best step is. So the clues are 30 years male with the lesions over the lower lip. Now if you focus the lesions, there are grouped vesicles. Right? If you see grouped vesicles, it is suggestive of herpetic lesion, right? Herpes means grouped. Herpes means grouped. So since it involved the lips, it is herpes labialis. Now the options given are Kevorchmon, Gram-Stein, Zangsmeer, and biopsy. If you suspect herpes labialis, the ideal investigation of choice is Zangsmeer. What will you see? You will see multinucleated epithelial GN cells. Why it is happening? The virus will infect the keratinocytes. Separate keratinocytes will be there. Na? When the virus is infecting these keratinocytes will become clumped and form a GN cell. That is the reason you will see GN cells in herpes infections. Now I will give some small clues about other tests also. When will you do Kevorchmon? Basically, Even if you don't know the diagnosis, whenever they give scaly lesions, you will do K-Watchman. When will you do gram stain? Whenever they give some wound or you will see some pus discharge or even pustules, you will do gram stain. Biopsy you will see in suspected nodules or plaques. When will you do slit skin smear? You will do slit skin smear whenever you see some thickened ear lobule, thickened nerves. Right? Those things you will do. Right? So the answer here is Zhang smear, which will show multinucleated epithelial giant cells. Next question. A 30-year-old patient presented with asymptomatic rashes over the groin. Woodslam showed following finding. The causative organism is. Here, the options given are Corynebacterium minutismum, Microsporum canis, Cutibacterium acne, and Malassezia furfur. First, you will make up the diagnosis, then we will identify what is the causative organism. The clues given here are there is an asymptomatic rash over the groin, right? That is the first clue. Second clue, they did a wood slam, which shows following color. What is this color? Basically, you may think it is a pink color. Basically, we will call it as coral red. So, if you see asymptomatic rashes over the groin or axilla plus coral red fluorescence, it will make up the diagnosis of erythrasma. Erythrasma is caused by an organism known as Corynebacterium minutismum. Okay, that is the straightforward thing. Corynebacterium minutismum leads to coral red fluorescence. Okay. What about this Microsporum canis? It is an dermatophyte. It causes tinea capitis. Cutibacterium acne is related to acne. Malassezia furfur is related to pityriasis versicolor, which is a fungal infection. Why they gave these options also here? Just to want to confuse with the fluorescence, because these organisms also fluorescence, right? For example, if you see Microsporum canis, it will show green fluorescence. If you see Cutibacterium acne, it will show orange fluorescence. If you see Malassezia furfur, it's shown yellow fluorescence. So just to confuse you, they gave other options also. Okay. Right? Now, they can just give the image and they will ask what are the composition of this or what is the wavelength. This is basically wood slam. It will give a UVA rays at the wavelength of 365 nanometer. You can remember days in a year. Okay, 365 nanometer. It is basically made up of a Wood's filter. It is basically barium silicate plus 9% nickel oxide. That is the composition. So this thing you have to remember. And the other things like what are the fluorescence of different organisms, you have to remember. In non-infectious, is there any use? Non-infectious dermatosis. Because you have seen only infections now. If you take a urine, it shows a red fluorescence. What will you think? You can think of a condition known as porphyria. If you see a white patch, it is becoming brighter white. It is possibly a vitiligo. These are the two common conditions. You can use wood slam. Okay. Next condition. Next question. A 40 years old patient presented with following lesions over the elbows, knees, and scalp. Which of the following is false regarding this condition? First, the clues are the lesions are present in the elbows, knees, and scalp. Elbow and knees are basically extensors, right? And in the scalp, the lesions are involved. So we are going to a dermatosis, which involves mainly extensors and scalp. Now, if you see an image, here you will see a well-defined plaque with silvery white scales. So, with the question we are getting, the lesions are involving the extensor and scalp, which are red plaques with silvery white scales. What is the condition which have silvery white scales involving extensor and scalp? This together forms a condition of psoriasis. Alright. Now, first you identify the condition. It is an psoriasis. Which of the thing is false regarding psoriasis? That is the direct question. Psoriasis is characterized by positive auspit sign. If you grade the lesion, if you do grattage test, you will see a pinpoint bleeding. That is known as auspit sign. Pinpoint bleeding, which is characteristic of psoriasis. And if you see the nail, you will see something like an oil beneath the nail plate, which is known as oil drop sign or salmon patch. If you see, the salmon patch is the most characteristic nail finding of psoriasis. So that is also out. Now only we discussed the scales are silvery white in color, so that is also out. So the remaining odd man out is Wickham striae, which is not seen in psoriasis. So you tell me Wickham striae is seen in which condition? First you will see what is Wickham striae. Wickham striae are basically these whitish lacy structures. Na? You are able to see here. Na? This whitish lacy network. It can be seen in mucosa, even in the skin lesions. If you are seeing this Wickham striae, you can blindly tell the diagnosis will be lichen planus. Other important points about lichen planus are that 6 P's you might be known before itself, like purple, polygonal, pruritic, plain topped, papules and plaques. Right? So Wickham striae is seen in lichen planus. That is another important point you have to remember. Next question. A psoriasis patient presented with following hand findings. X-ray showed penicillin cup deformity. What is the diagnosis? So first, the patient is psoriasis patient with following hand findings. Like if you see the image, you can see some points like the digits are shortened, right? If you see very closely, one digit, one phalanx is protruded within the another phalanx here, right? Something like this. Here, if you are able to see, this phalanx is protruded with this. It is known as telescoping of digits. And these are very deformed digits, right? You see such was picture with something like a penicillin cup deformity. This is a penicillin cup deformity. Normally it should be like this, na? But here you can see it is like a penicillin cup deformity. You see this deformities with X-ray finding of penicillin cup deformity. It is suggestive of diagnosis known as arthritis mutilans because the digits are mutilated here. You can easily make out. So the diagnosis arthritis mutilans. Another important point is it is the most severe form of psoriatic arthritis. The most severe form of psoriatic arthritis. What is the most common form then? Asymmetrical oligoarthritis is the most common form of psoriatic arthritis. Another important point you have to remember is all the psoriatic arthritis are RA rheumatoid factor negative arthritis. Okay. Axial arthritis and RA-like arthritis are other types of psoriatic arthritis. Next, a 30-year-old patient presented with following lesions over the elbow, knee, and scalp. Which of the following is not a nail feature of this condition? So here also they mentioned it is involving the extensor and scalp.